Thank you very much. We're going to be discussing how to use intracardiac echocardiography guidance for deployment of left atrial appendage closure devices, specifically Watchman, but this basically applies to all devices available. I've had some conflict of interest as shown here. And the first use of intracardiac echo to image the appendage was dedicated to ruling out left atrial appendage thrombus. And this was published in a several case series from UPenn and Mount Sinai group, where they showed that from either the left atrial appendage body or the pulmonary artery or even the coronary sinus, you could image the left atrial appendage with decent quality, enough to rule out thrombus with as good a sensitivity and specificity as TEE. These are examples of images of the appendage from the left atrial body, where the first thing you see next to the transducer is the left atrium followed by the left atrial appendage. From the pulmonary artery, you have to torque the echo beam facing down, and you will see the tip of the left atrial appendage immediately underneath the pulmonary artery. And from the coronary sinus, you have to face the transducer imaging up so that it images the left atrial appendage. That is kind of background knowledge. When you try to apply the capability of intracardiac echo for appendage closure, you have to keep in mind the imaging needs for left atrial appendage closure procedures. There are echocardiographic needs as well as angiographic needs. In terms of echocardiographic needs, you need to rule out thrombus as the first step before you even start the procedure. You use echocardiographic guidance for the transeptal puncture, not necessarily mandatory, but it's commonly used. You use it to measure ostial diameter in different axes, as well as appendage depth. Once you deploy, you use it to check device position, compression, and seal. And then you use this by sequentially sliced images of the appendage using multiplane imaging by turning the angle of the echo beam in TEE. No, there's no single view of TEE that describes the entire left atrial appendage anatomy, and multiple angles are usually required. And that's why we have protocolized TEE views in Watchman and Amulet or any appendage closure procedures. In terms of angiographic needs, the nice thing about angiography is that it does show you the entire left atrial appendage structure and delineation of the lobe architecture, but also it's a shadow, what you see on angiography, so multiple angles are also required. It allows you to assess the depth of sheath insertion and in real-time imaging for device deployment. So one of the points of my talk is that as far as the echocardiographic needs, the transeptal puncture, appendage thrombus, ostial diameter, lobe length, and device position, seal, and leaks, all of them can be covered by intracardiac echo, with the advantage that it adds patient comfort because it reduces the procedure invasiveness to 2 venous punctures. No more anesthesia, no more arterial lines or other things that anesthesia may decide to implement on your patient. Here you just do 2 venous punctures with local anesthesia and conscious sedation, which eliminates the logistics, the complications of the procedure in terms of scheduling, coordination of different teams of people, lab time, etc., to a simple conscious sedation procedure, very similar to a stent deployment. And I will make a case that in our experience, it has led to fluoroscopy reduction as well. But you need to abandon the TEE protocol mindset. No more fixation on different views and different angles to image the appendage. You have to change your mind out of that. First step is a transeptal puncture. There's textbooks and video DVDs on how to do transeptal puncture based on fluoroscopic landmarks. Basically, the idea here is you need to make sure you know where the fossa ovalis is, and structures to avoid are the aorta, obviously. If you go to anterior, the pericardial space. If you go to posterior, and you have some landmarks that we used to be taught classically based on fluoroscopic indicators of where the aorta is, the His bundle, etc. And for appendage closure, we are taught when we start these procedures that you need to have a posterior and inferior puncture. That was deeply ingrained in most of the reps and technicians that serve support these procedures. But I would make a case that sure it is important to do an inferior puncture, but I'm not so sure it is so important to do it posterior. You need to do it at an angle where you have a straight line from the septum to the appendage. And that's typically in this cartoon shown here where the recommended puncture site for the appendage closure is. I would argue that anywhere low, particularly I prefer to do it a little bit more anterior, is good as long as you stay in the fossa ovalis. So, can ICE cover the imaging need of the transeptal puncture? Specifically, yes, and more. It allows you to advance a wire into the SVC without checking fluoroscopy. It allows you to see how you advance your sheath into the SVC. Then you load the needle and you drag into the right atrium, and you can see the dragging in real time. It allows you to see the engagement and allows you to refine of the fossa ovalis and refine the position of your transeptal assembly within the fossa ovalis. You see the crossing of the septum with the needle without fears of going too far in if there's an aneurysmal septum. You see the advancement of the sheath into the left atrium, and you can actually see the thrombus, if anything, if it's present. We have recently written a hands-on paper on how to do ICE-guided appendage closure device implants, and it's just published in Heart Rhythm last week. So, ruling out thrombus as a first step. From the right atrium, you advance into the right ventricle. That's usually my first screening view. I get into the RVOT, and from the RVOT, you can image the appendage. This is the appendage, looking at it from the RVOT. Here's the same thing. You see some portions of the pulmonic valve, some portions of the left main and the LAD, and the appendage is here. You see the tip of the appendage, and if you adjust the views, you can see the ridge and get your preliminary measurements of ostial diameter and depth of the appendage. And every case is different, but the bottom line is that you can get a first screening for thrombus and a first measurement of appendage size from the RV. Next is the transeptal puncture. And I love this view where you go up to the SVC-RA junction with the transducer, and you can see the anatomy is very clear. Superior vena cava, this is the septum as the superior vena cava joins the right atrium. Behind the septum, there's the left atrial body, and on top of it, between the SVC and the left atrium, you have the right pulmonary artery. We advance the wire into the SVC, then we follow the wire with the sheath. You can see here, you load the needle. I like to flush and see the streaming of saline from the SVC into the right atrium. Then you drag and you engage the fossa ovalis. Then you cross the septum with a wire. You want to have the wire into the left superior pulmonary vein. And then you advance, you change whichever sheath you use to cross. You have to take it out, put a stiff wire in the left superior pulmonary vein, and then advance the 14 French sheath for Watchman delivery. I like to dilate the fossa ovalis several times with the 14 French sheath so that the puncture gets stretched, because it'll have to fit both the 14 French sheath as well as the ICE catheter. And this is one of my favorite things to do, which is to advance the ICE catheter, the ICE probe into the left atrium, simply following the wire. This is a very simple, it looks very difficult, but basically as you bend the ICE catheter, you will see here the wire coming to the vertex of your image, and that means you're right there, and then you advance towards the left atrium, and there you go. Now you are in the left atrium, and then you will have these amazing views of the left atrium, of the electrical appendage from the left atrium. There are several views that we've kind of come up with and we've defined, although they're relatively straightforward. There's nothing really magical about what we've done. One nice view is the transmitral view. So in order to illustrate this view, we did a few cases with Carto sound so that you could see in the context of the three-dimensional anatomy of the left atrium where the transducer was. So here we've done transeptal and we advanced transmitral, the ICE probe, and we rotated so that the echo beam faces superiorly towards the left atrial appendage. So this is the image that corresponds to this catheter position. We have the transducer is just past the mitral valve, where you can see the mitral annulus here, and on the epicardial aspect, you see the circumflex and the great cardiac vein, and on top of those, you see the left atrial appendage. This is one of, it's hard to get sometimes to get the transducer to go across the left ventricle, but once you do that, it's actually a beautiful view. A more practical and more stable view is engaging or advancing the ICE catheter into the left superior pulmonary vein. That's relatively straightforward to do. You don't even need to use fluoroscopy because you can see the images and you can see the transducer going into it. You will see on ICE the ridge that goes all the way to the transducer because your catheter is past the ridge deeper into the left superior pulmonary vein. And then you rotate the echo beam, and from this view, you see the appendage from behind it. And you can actually rotate clockwise or counterclockwise to make this echo beam look lower or higher into the appendage body. And depending on the anatomy of the appendage, you may see different lobes with this view. A simpler, but perhaps less stable view is from the left atrial body. You park the transducer in the left atrial body and aim anteriorly, and you will see the tip of the ridge and the appendage, as well as the circumflex in some cases. So these are the most commonly used views to see the left atrial appendage from the left atrium using ICE. So we've seen it, we've taken measurements. We then engage the sheath into the appendage. We first advance the pigtail, and you can do this with ICE guidance only. Pigtail into the appendage, then you advance the sheath over the pigtail and take your injections, your angiograms. You can see this appendage, kind of a chicken wing with a posterior lobe going backwards, perhaps below the pulmonary artery. So we don't have a lot of usable depth. Nevertheless, we deploy the Watchman. It takes its shape, and then we obtain our standard angiographic views to confirm that it's placed in the right location. But we can also, and we do need also to see how the appendage looks on echo. So with intracardiac echo, you can use Doppler to see leaks. And in this case, what we do is, instead of using multiple angles as you do with TEE, where you rotate the angle of your echo beam, what we do here is we have a fixed, a relatively fixed angle. The intracardiac echo is not multiplane, so we have a vertical echo beam, but what we do is we rotate from posterior to anterior along the Watchman, and we put Doppler, and we can see leaks just the same. This is one example where we go from frontward to backward. Well, it doesn't want to play. And then here we are using the tug test to see that the Watchman is engaged, and then we release the Watchman and we let it go, and it stays. Okay. We collected I say large, it's up for you to judge, but anyway, 100 patient series between us and Mount Sinai with the collaboration of Vivek Reddy. And we had 50 patients that were implanted with ICE guidance only, compared to 50 patients that were implanted with TE guidance. This is a non-randomized kind of consecutive series. We had a reduction in fluoro time with ICE. In terms of the appendage width and depth were very similar. The device size distribution were very similar. The compression was actually slightly greater compression in the ICE-guided group. Number of deployments were very similar. The number of the devices didn't recapture, number of recaptures, all of those were very similar. Most importantly, the peri-device follow-up leak on TEE was very much similar. Basically, only one patient in each group had a leak more than 5 centimeters, and about 27-28% of the patients had leaks that were less than 5 millimeters, and 72% of the patients had no leaks at all. So very comparable outcomes when using ICE guidance compared to TEE guidance. What was more interesting for us was that the time from the patients making it to the room to out of the room was significantly reduced, 20 minutes less. From puncture to closure, the procedure times were exactly the same. So we didn't take any longer by using TEE. But the sedation to puncture was a lot less, from closure to out of the room was a lot less, and the turnaround time was half an hour less. So we saved a lot of time in the procedural logistics by using TEE, not just using TEE, by not using anesthesia. That is a big deal. When you have to incorporate a separate team, they have to make their own decisions. Anesthesia elevates the risk, elevates the complexity of the procedure, and that necessarily adds time. Interestingly, we also were able to get the hospital charges, and as ridiculous as they seem, $120,000 of charges were very similar between ICE and TEE. The costs were slightly more for ICE compared to TEE, but it didn't reach statistical significance. Basically, what you saved by using TEE, which you don't have to buy a probe, you spend in recovery time and use of the recovery room by virtue of using anesthesia. Of course, the professional fees were less because we didn't charge anesthesia fees. So we probably made the procedure a bit cheaper. So in conclusion, ICE-guided imaging covers the entire echocardiographic imaging needs of Watchman deployment procedures, eliminates the need for general anesthesia, expedites the procedure logistics with a quicker turnaround time and simpler sedation strategies, does not compromise on the procedural quality, and it leads to similar hospital charges and costs. And of course, the technology is going to improve. We have recently engaged in collaboration with a company that makes a 3D ICE catheter by Nuvera, and it creates these spectacular 3D images that you can see here, where you can actually measure in one single view the entire. You can see the ostium of the appendage. You can see this moving, and you can assess the Watchman deployment with much better quality of imaging than TEE or existing ICE. And I'll stop there. Thank you very much for your attention.